join us today. It's just a great opportunity to talk you through the joint study that we've worked on with Humber and North Yorkshire ICB. And we're going to talk you through the findings from this study and white paper and answer any questions that you have towards the end of the session. You're going to notice that chat is actually turned off, but Q&A is enabled. So we'd like to invite you to post any questions that you have at any time during this session, and we'll have our speakers address them towards the end. So I'll be your host for this webinar. My name's Jailan Yahia. I work on communications here at Medibase. And I'd like to first give you an overview of the company and our product in case you're not familiar with us. We are a leading UK-based cloud-native EHR solution. We've been serving the private healthcare sector for around 18 years, specialising in primary care and occupational health, as well as secondary care. We have also been working with NHS Digital for a number of years on a variety of different projects to integrate some of Medibase's functionality with NHS public health records. For example, we have a direct integration to GP Connect to retrieve data from the GP record to facilitate continuity of care. In 2018, Medibase software was also the first new entrant onto the NHS GP IT Futures framework in over 12 years, and it is the only online supplier to be listed on the catalogue. In 2018, we were welcomed onto the GP IT Futures framework, but we've also been working with a number of other NHS organisations and pilot projects, and this is a great example of the kind of work that we do with our system. So just to give you an overview of the topic we're going to be covering in more detail today, we're specialists in digital communication. We have sent over 30 million patient SMSs for our customers, but this project demonstrates our company's wider goal, which is to provide the tools to tackle healthcare management challenges at scale and improve patient care through digital interoperability. We are going to hear from 3 speakers today, all of whom were instrumental in planning and executing the pilot study to determine if we could increase patient engagement and referrals to the National Diabetes Prevention Programme using patient identification tools and automated text message prompts. Our first 2 speakers are from Humber and North Yorkshire ICB, who commissioned this pilot. Dr. Tom Milligan, Clinical Lead for Diabetes in the region, followed by Scott Walker, the Senior Partnership Officer for Diabetes. We will then gain a more technical perspective from Erin Johnston, who is NHS Product Owner at Medibase. So first, I'd like to welcome Dr. Tom Milligan. Dr. Milligan will take you through the benefits and outcomes of this solution from a clinical context, and he will also talk to you about the opportunities to provide care to pre-diabetic patients not being reached by traditional methods while remaining focused on not increasing the workload in the care setting. So thank you. Over to you, Tom.
Hello, welcome all. So I'm a GP and I specialise my medical practice with working as a systems thinking specialist. That means I use that management approach and a healthy knowledge of behavioural economics to help me understand complex systems in ways that others don't. It enables me to save time, drive efficiencies and increase safety for our patients right across the NHS. I've had industry recognition for saving the most amount of time in primary care, and I've been named the NAPC Clinician of the Year, as well as the GP Awards nominating me their Healthcare Leader of the Year. A quick example of just one thing I've done that reached national prominence was to safely allow the administrators to file letters rather than GPs, and this saved the NHS 20 minutes of doctor time per day, saving £230 million annually. Since 2019, I've been the diabetes lead in Humber and North Yorkshire ICB, and I became interested in diabetes as it's the costliest disease to the NHS, soaking up to 10% of the whole budget, and we know it will affect 1 in 10 adults by 2035. I realised the tide was changing with the groundbreaking work of David Irvin and later the DIRECT trial, which effectively showed that if you could lose weight, you could reverse the harms from your diabetes. So today, I'm proud of and grateful to our audience. We have health leaders, commissioners, population health experts, GPs, diabetic nurses, and IT specialists, among many others. With this much talent, I think together we could tackle some pretty big challenges. Not least, I'm sure we're united in our views. We want to preserve the NHS and we want to stem the harms of diabetes. So welcome to all. Non-diabetic hypoglycemia, or pre-diabetes, is a precursor to type 2 diabetes in most cases. This is where a patient's average sugar, or HbA1c, is between 42 and 47, and we know in that group that over their lifetime, half will develop the disease. Not only is diabetes the leading cause of blindness, renal failure and amputation, but if you're lucky enough to get it in your 50s, it will on average reduce your life expectancy by 6 years. NHS England recognised this in 2016 and invested heavily in the National Diabetes Prevention Programme. This is a behavioural modification programme over 9 months that's either digital or face-to-face in groups. In the last year, we've had scientific research showing the effectiveness of the course. And we found out that if you could complete 60% of the course, then you could expect to lose weight by 3.3 kilograms, drop your sugar by 2 millimoles, and you could reduce your personal risk of diabetes by 37%. To date, the NDPP nationally has received 1 million referrals from primary care. We know that that includes 300,000 people completing the course in England. And this has resulted in 18,000 fewer people than would have been expected to get diabetes who didn't because of the course. We also know that the longer you attend the course, the more weight you lose and the lower your HbA1c will drop. And with 200,000 places, this is the most comprehensive population cover for this sort of lifestyle course anywhere in the world. So there's much to be proud of. But how are we maintaining that level of activity? And it turns out there's quite a lot of work. And working in our ICB, we've tried training practices, we've provided enhanced searches for practices, there have been financial incentives, both regional and national. And we know from NHS England that they have mentioned a case study where they'd gone to a 14,000 patient practice that referred no patients in the previous 3 months and worked with them to change their approaches. They use staff training, process mapping, reimagining templates, coding, and ultimately delegating the task away from GPs. They ran this pilot for 3 months and then reported on the effect this has had. 26% of patients with pre-diabetes have been referred onto the course. With my systems thinking perspective in mind, I wondered if GPs had spent their time doing this, what were they not spending that time with the rest of their work? And was that impacting other areas of their service in a negative way? It made me wonder whether the solution was scalable. And of course it is. We could teach that approach to 6,500 practices, but only likely to be successful if that was the only thing GPs were doing. I also wondered, is that advantage forever? And thought perhaps if coding changes or staff left, then it might not be maintained. Any solution we developed needed to be better than the current gold standard. However, if we want to improve the current status, we've also got to reverse the telescope to see what's going on in the wider system. We know that so far, only 6% of the total target population has been able to attend the course. And we know that the results we had that were so fantastic only took place from 3% of people who completed the course. Unfortunately, the pool of patients with pre-diabetes is increasing, not shrinking. It currently stands at 5 million people in England. So far, we've coded 50% of the cases, which is a colossal effort from primary care. The downside of it being 50%, not 100%, is to do with recalls and being able to have the ability to safely invite people back in to have blood tests on a yearly basis. If we don't catch them on the year they change, we can't optimise their medicines to prevent harms from the disease. Most areas are also struggling to fill their current quota of patients. If we maxed out our national places for diabetes prevention programme, we'll only tackle 4% of the backlog each year. Potentially, that leaves 4.8 million people annually who are eligible for the programme, but for whom there's no current space. 5% of these people are expected to develop diabetes each year it's left untreated. And that would add 250,000 new cases of diabetes to the NHS caseload. I remind you that there's only 200,000 people that are on the course each year, and whilst individuals can reduce their chance of diabetes by 37%, that's only if they can complete the course. In short, the numbers are rising. If we carry on with our current approach, can we manage? I worry we can't. In the face of an ageing population and preventable obesity epidemic, then costs are going to rise a lot. Not tackling this will inevitably lead to the population thinking, if I'm slim and young, why should I pay for those who are not? Perhaps a private healthcare system is better for me. I feel this poses an existential threat to the current funding and delivery processes within the NHS. Systems thinking encourages me to consider the fixed obstacles in the current system which may prevent easy change. I'd argue that the data laws were not designed with the NHS in mind. The data is locked in 6,500 data centres and each has a data controller. We often call these GP practices and GPs. Our money and specialists are siloed in their specialty areas, making cross collaboration on projects hard, and complex incentives across the wider system can make it harder to work together too. We've just seen the 5 years it's taken for the robust research of the NDPP to come through, and so only now we can decide if we want to change investment or entry criteria. I'm concerned that the pace of fixing the problem is slower than the pace of the problem getting worse. The old approaches will not work. There needs to be a new idea which can tackle these issues. I was aware that when creating a safe and effective solution, all of these problems needed to be overcome. Formation of ICBs creates an opportunity and a threat, with more freedom to tailor help for different populations, but the siloed ways of working prevents cross-specialty collaboration. Typically, we spend about 0.1% of the NHS money on primary prevention. In a recent blog, the King's Fund joining the DOTS initiative have commented on this problem just in the last week. Population health is not an optional extra, but a core focus that's needed to create a sustainable model for health and care. So I want to look at different parts of the system and why they might find it hard to change their practice. This is a graph regarding GP activity. In grey, you can see the number of patients increasing, and we all know that the bulk of general practice is work done in the over 65s, the line you can see in green. Over the last 14 years, the number of GPs has decreased by 8%. But to expect GPs to organise and run population health management, I'd hope they've got the following skills. They need full training and understanding of data governance. They need to be experts in complexity science, experts at interrogating incomplete data sets, and know all about digital engagement. Statistical knowledge is needed to see whether interventions tried worked better, and an ethical framework is needed, which offers interventions that are right for their population. I worry they might be better at helping patients in front of them and can spend the time saved delivering core work in a more sustainable way. How about wider parts of the system? I think PCNs are keen to do the work. One example near me, who's on the call today, did an amazing job with great searches, very similar to what we've done here, and they'd pulled together the 5 practices to do one data pool, which was then sent to an online print drive, which wrote letters to patients. Only when I thought about it, there might have been some problems with that approach in the longer term. Patients were advised that they needed to call back to the GP surgery if they wanted to be referred. That was going to create work for the practices. They also had the option to get a GP appointment if they wanted to understand more about the course, and that in itself was going to create more work within the practice. It also made me have concerns about fairness. What happens if one area uses up referrals that could have been spent by someone else just because they went first? Also creates me concerns about cost. If the areas use the advanced searches, then I know they can identify 25 times the current number of eligible places than there are spaces. ICBs also struggle to coordinate and manage flow as they've got limited control over practice activity. The data they use is often late or scant. Commissioners of services also struggle because they don't have robust real-time data to make decisions on changes to courses or to providers. And researchers try their best to fill this void, but the realities of formal research is it takes time to approve, gather and publish decent research, and I feel that new systems need to be better. There are 4 areas from a systems thinking perspective I feel we could target to improve the system. The first, not involved in our project, involves better identification of people with pre-diabetes. This may mean using advanced and new GP recall systems to prioritise sending people, finding people who've not had an HbA1c test, rather than testing again someone who was already negative or could be at low risk. And that could be done by changing GP recall systems. Apologies. Our approach was to look at identification of pre-diabetes and GP records using enhanced searches. These were based on pure searches of the GP data, looking at sugar levels and inclusion and exclusion criteria for the perfect cohort of patients who are suitable for the programme. I said also that we wanted to work on enhancing the referral processes so that we could use digital engagement and automate referrals onto providers. Before we complete though, there's another approach we could also look at. Encouraging retention's ostensibly a provider challenge, but perhaps we could help them. If we sent a priming video prior to people going on the course and they knew all about the benefits of the course before attending it, well, who's to say they wouldn't attend for longer and we wouldn't get better results? So before we start to think about our future results and how we've done, we need to compare to a reasonable benchmark of current good practice. And I would say that the NHS England pilot had 26% of people getting into programme.
Thanks so much for those insights, Tom. So now we're going to hear from Scott Walker. Scott is the Senior Partnership Officer for Diabetes in Humber and North Yorkshire. He's going to be sharing his experiences and insights on this pilot from a process perspective, so including managing patient invitations and referrals to the programme en masse using a structured approach. So I'm just going to hand over now to Scott.
Thank you, Jai. So welcome everybody. Thank you for taking some time out of your busy day to listen to us just for an hour. So in discussion with Tom one Friday lunchtime, we recognised that we, like a lot of programme areas, were struggling to achieve our targets for NDPP referrals. And we both felt that we were missing a trick somewhere. There's got to be an easier, better way to do this. We came up with a concept and we floated the idea past some colleagues at NHS Digital, and they were taken by what we were saying and thought that it warranted further exploration. They made an introduction to Medibase and we talked through what it was that we were hoping to achieve. And it was one of those conversations where when it finished, I thought, they get it. They just get it. We had then the kernel of an idea, but we obviously had to get some partners involved. So we had some scoping conversations with our NDPP provider, Xyla, and they were very keen to sign up to the concept. They could see the potentials in it. We then had to identify where we were going to try and work within this very limited pilot. Initially, we discussed it with two CCG leads, one from North and one from North East Lincolnshire, because they were in contract with Care Plus Group, CPG, to provide some GP data quality support. That meant that they could access records and run searches. They too were keen to be involved with the programme, with the pilot, sorry. And we set out with a plan to identify 4 practices, 2 in each of the CCGs, out of a total of 45, it should be noted, and just see what we can achieve by moving through the solution. We formulated a plan. We talked it through, everybody around the table, we came at it with a blank piece of paper, and we came up with a rudimentary workflow. This was taken away and worked up into something that resembled a solution with Medibase colleagues. And during those discussions, we agreed that it was important that we tested both an opt-out and an opt-in model. For those who are not familiar with that terminology, opt-out is where the patient is invited. They're advised that if they do not proactively opt out by the closeout date, they will be converted to referral. Conversely, the opt-in is the patient is invited to signify that they would like to opt in and be referred. CPG went away and they identified a small number of practices for us. These were all very similar in terms of the list size, eligible cohort size, and where they sat in terms of deprivation. And we felt that that was something that this could lend itself very neatly to addressing. One big question was posed, and I'm sure it's the bane of most of our lives, the IG, the information governance. We took quite a pragmatic approach and we decided that the best thing to do was to actually compartmentalise that down. We didn't need one overarching agreement which covered the solution, the process and the pilot from end to end. Rather, we needed the correct processes and paperwork in place to ensure that as things were passed between CPG to Medibase, Medibase onto provider and back to CPG, that the appropriate data sharing and DPIAs had been done. We got that boxed off. We got some input from our CCG leads locally, and everybody was very happy with how it was contained and how it was planned to be managed. One other question that was posed to us was, what about those people who cannot or have not given consent to receive text, those who were digitally excluded. Yes, we could only contact those patients who had that criteria ticked on the clinical record, but this was a very small scale pilot and we felt that it was our first foray in, let's see what we can achieve. We've since discussed this, and as the solution is getting worked up and refined, we're hoping that the second strand would be those patients with an email, and then anybody else who fell out with those two digital areas, we would aim to contact by a more traditional means, i.e. an envelope through the letterbox. But again, we could apply some clever thinking and do that through digital mailing using electronic mailing solutions. So we had a plan, we worked up a process, really very simple, 4 steps. Patient identification from CPG being step 1. Those patients were then passed across as a CSV to Medibase. Medibase dropped them into the machine, for the want of a better word, where the parameters were set, be it the opt-out and the timings for the closeout. We agreed that 14 days was a reasonable amount of time, and that automatically at day 7, those patients that hadn't responded would be sent a reminder text. So one Friday morning in January at about 11 o'clock, the text went out. January, we sent out 433 invitations, inviting patients to opt out of being referred. At the end of the 14 days, 363 of those patients, 84% of them, were converted to a referral. They were then passed electronically and securely onto Xyla to be processed as a live referral. Those that had opted out were passed back to CPG to be coded as offered and refused NDPP. Likewise, towards the end of February 22, 11 o'clock on a Friday, there was no science behind that. It was just when we were ready to go live with the original pilot. We sent out 362 invitations in an opt-out model test. From that, we got 139 patients who proactively opted in, that being 38% of those invited, and they were duly processed in the correct direction, be they referral or refer back to the GP, the primary care centre, as offered and declined. What impact did this have on what we were doing? As you can see here, this is a run of graphs that shows the 2 months pre, let me just get the highlighter, shows the 2 months pre the pilot, the month in between, and 2 months on the other side. Now, I'm going to stress this very strongly. These figures are all 45 of the practices in those 2 CCG areas. The impacts here and here are a result of those 4 practices, 2 in each pilot group, being managed and processed differently. So I think you would all agree, or I would like to think that you would all agree, that it paints a very, very strong picture as to what can be achieved just through that difference in approach and planning the activity. So we've done the pilot, we've been involved with the white paper, we're presenting here today, and actually me as programme lead for Humber and North Yorkshire, I'm very excited about the future and what this can do for us. Some of the lessons that I've taken away and that we are currently working with are a coordinated approach. Target your practices. We have an extremely competent and very personable engagement lead through Xyla, who is reaching into practices and supporting them to do a more refined search, a coordinated approach around when groups will start. And we have actually seen that patients who were referred following a bulk invite were in groups 3 weeks after the referral being received. So I think that's a pretty good return on an hour of practice time, and that is all it would take. We have seen that using this solution, there is a significant reduction in the workload at primary care. Searches can be managed, invitations can be managed, and the outcomes can be managed and properly documented and logged. One of the key things for me was how controlling the communication flow can make significant differences to knowing where a patient is in their journey. We controlled it as best we could. It was open. People were asked to text back. And as such, we got some non-standard responses. Amongst them was the, is it okay if I stay in bed? And another asked, is this message for my mum? We can't control everything, but we can certainly exercise more control and make things an awful lot smoother. With that, I will move on and hand over to Erin, who's going to talk to us about the technical aspects of the pilot.
Thanks so much, Scott. So I'm just going to hand over to Erin, who's my colleague here at Medibase. Erin's going to talk you through the technical tools we use to run the pilot and summarise the methodology we presented in the white paper, outlining the ease and the flexibility of the solution and its ability to support a range of population healthcare management programmes, not just diabetes, but in the wider healthcare setting. Thanks, Erin.
Thanks, Jai. Hi, everyone. Now, I'm going to talk you through the software side of this project. Medibase has been working alongside the NHS for a number of years. We're on the NHS GPIT Futures Framework, and we spearheaded this pilot alongside Humber and North Yorkshire ICB. Together, we wanted to test whether a strategic, focused approach that utilises digital communications and is delivered at an ICB level could increase uptake of the DPP in this region. We also wanted to uncover learnings that could be shared with other ICBs across the UK to improve uptake nationally. In order to achieve what we thought was possible, we used the pathway system within Medibase. The pathway system allows the automation of business and clinical decision workflows to ensure the right information is given to the right user at the right time, resulting in better, more confident decision making. The pathway system is safe and secure by default, thanks to its underlying technology, meaning that destructive pathways can't be deployed. We build pathways using configuration, not code, which gives us agility and flexibility in deployment and the ability to adapt quickly to changes in scope. Using the pathway system was a great fit for this pilot. It allowed us to bulk upload a number of patient demographics and run a unique workflow for each one. This allowed bespoke communications to be sent, a timer to be in place for reminders, the patient's answer, either opt-in or opt-out, and a close of the pathway at a certain date and time. It was decided that we'd run 2 pilots. One would be for opt-out and one would be for opt-in. We ran these pilots using 2 different GP practices per pilot so that we could compare the numbers to determine the rate at which responses were sent back and the numbers which went on to be referred. This is the workflow we used for the overarching project. Stepping through this, we have the first action, which was to identify eligible patients and import them into Medibase. Working alongside CPG, who were able to access the patient data for the chosen GP practices, CPG were able to run searches using the criteria for eligibility into the National Diabetes Prevention Programme. However, we did add an extra criterion for the pilot, which was that the practice must have a mobile phone number for that patient. Once we had identified the eligible patients, they were sent via NHS mail to be imported into Medibase. Each patient was placed on their own pathway and a communication was sent out. It was agreed as a team that the pilot would run for 2 weeks. A communication would be sent on day 0. A reminder would be sent on day 7 before the pilot ended on day 14. This slide shows you an example of the communications that were sent out for the opt-out pilot. Our communications can be personalized automatically for each patient, including demographic details, as well as things like the date code, which further reduces required manual intervention. This first communication informed the patient of the program, a confirmation of their most recent blood test date, and the indication that this was in the pre-diabetic range. Information in the message also included that the program was run remotely due to COVID. A number to contact to opt out was included so that the patient could remove themselves from being referred if they chose to. The final piece of information in the message was a date by which the patient had to opt out in order to prevent the patient from being referred through to the program. If the patient did not respond after the first communication, then a secondary communication was sent after 7 days. This communication was just a repeat of the first communication and contained all the same information. If the patient did respond to the message, then a confirmation text was returned and the pathway would end for that patient. Looking to the end of the workflow, if the patient did not respond to the text at all throughout the 2 weeks, then the pathway would end with the outcome dependent on the chosen method. Opt-out meant that that patient would not be referred into the program and no further action would be taken. Opt-in would mean that the patient would be referred into the program and then be contacted by the referral provider, who for the pilot was Xyla. Once the 2 weeks had passed, the patients were placed on one of 2 reports in Medibase, a report that contained all the details that Xyla needed for the referral into the program, and a second report that was sent back to CPG so the patients could be coded correctly within their GP system as having been offered and declined the program. To touch on a little more of the technical detail, this workflow shows the steps within Medibase that were taken to progress the patient along their pathway. Instead of walking you through the theory of the pathway and the steps taken, I've got a demo video that will show you this in working order. Once Medibase had imported the eligible patient data and initiated the pathways so that that first communication was automatically sent out to patients, it was then over to our external third party. Due to the limited nature of the pilot, we did have CPG monitoring the number that patients could respond to and then manually entering that patient's response into Medibase. A patient could be found using their mobile number and then taken through to their pathway. Once the user is within the pathway for that patient, they can then select whether the patient is going to opt in or opt out, depending on the chosen method. On pathways where the patient did not respond, the timer would ensure the reminder was sent at the pre-configured date and time, and then the pathway would close automatically at the end of the selected time period. A point to note around our pathways is that because we're recording the response within Medibase, as well as sending the text from there, we can make sure that all the workflows are up to date, accurate, and personalized to the patient in question. I want to touch on some future development. There's huge benefit to using the pathway system for an at-scale management of patients who require an invitation and referral into a program. You saw from the pilot we ran that there was a couple of manual steps, which worked with the small-scale pilot. However, we've mitigated this by putting into development the option to respond to an SMS and this to automatically action the next step in the pathway. This would allow for almost end-to-end automation for communications to patients. This pilot was specifically targeting diabetes, but it can be also adapted for any program of work that requires mass communication using digital engagement with little manual intervention. This can be used across the population health landscape. Using Medibase pathways brings many benefits in the current process. Implementing a solution that requires that reduces clinician and admin time by removing the need to search and send letters to patients. This also reduces the cost, as using traditional methods of communication requires the use of stationery, such as envelopes and stamps. The ICB has the control on variability of how and when the patient is contacted. A text is almost instant, whereas a letter can take days to arrive. A set time can be pre-configured for the SMS to go out to the patient, allowing the ICB the flexibility to send one on a Monday at 9 a.m. or even on a Friday at 3 p.m. The solution is light touch and repeatable, allowing this process to be run multiple times with different patient information. But most importantly, this solution is not about one core disease, but it's flexible and adaptable across the whole population health programs, allowing an ICB to cater to their own needs and targets.
Thanks so much, Erin. So I'm now going to just pass you back to Dr. Milligan, who is going to talk you through the learnings and hopefully answer any questions that have come through during the session. So back to you, Tom. Tom, you're on mute.
It was fantastic, though. So I hope I'm forgiven. So thanks ever so much, Jai. Before we wrap up, I'd like to go into some more detail about these results and the implications of what we found. I know that some people will want to know far more before endorsing the approach. The first one to tackle is the opt-out, opt-in differences. Were they statistically significant? Well, of course they were, and we knew that they would be because this approach has been shown multiple times in the past and was highlighted in the work of Thaler and Stunstein, who, as part of their Nobel winning work, helped us understand human behaviour in complex systems. But imagine if we were the discoverers of this, not them. A good question and just 30 to 60 minutes of human work, followed by an automated process that gave you a result within hours of the testing ending. However, I'm sorry we can't share the results from completion with providers owing to commercial interests, but it's safe to believe that our referrals were broadly in line with expected outcomes and we were pleased with the results. We've shown that we can improve referrals without impacting on the ability of providers to run the programmes. For some, that won't be enough to make any change, there's still not enough evidence. They would advocate for a wider formal pilot in NDPP and only consider any expansion once it was proven. For others, there's more than enough evidence to realise we could be making the whole system better and all of population health better by investing their own time and thought into maximising the technology. We were searching for an answer to NDPP for ours and other areas across the country to have a slick method to meet quotas while saving time. I feel we've achieved that. The real finding, however, was an accident, something we weren't expecting. That an existing technology used commercially in a totally different sector could be repurposed to answer arguably the biggest need in the NHS, a robust solution to population healthcare. Understanding the normal use of this technology will hopefully draw some useful parallels to the things we struggle with in the NHS. So I'm going to share with you a story. This is about a company called Widgets Are Us. They're national company responsible for making highly prized widgets of quality, and they use Medibase. They have scores of factories and tens of thousands of workers. They have a national board who sets strategic direction, are interested in the finances of the whole. They also employ an occupational health doctor to ensure the staff are safe and optimally fit to do their jobs. The workers need to be fit to make the factories work. Each worker needs just the right training for their job. Overtraining wastes money, undertraining slows production. They receive questionnaires they fill out each month. They're digitally engaged when courses are due to run out, and the system automatically books with them when critical masses are reached. The factory managers need dashboards of activity and finance to optimise staff fitness in their domain, and the OC Health doctors can monitor the impact of new courses on productivity. The board can set directions, suggest quotas, and manage the finances. They have customisable dashboards to see any metric they wish, but certainly not patient level data. I asked a series of questions about my newfound interest in the widget world. And one of my questions was, if there are more workers suitable for a course than places on it, what are the options? And one of the answers I got was that some could go on one course and some could go on another approach. That could be done randomly for fairness, or you could prioritise based on need, based on other searches and parameters. You can tell the system what you need. If there are differences between approaches, i.e. one course is better than another, then the system can tell you, is it better and by how much? And lastly, I asked, if this widget company is uploading information to Medibase and has their own systems, how are they sending you the data? And the answer was CSV files. So I gave up on the widgets thing at that point. I just cut to the chase. I said, look, in your medical business, can you interact with NHS patient records? And the answer was yes, through GP Connect. And I said, okay, can we do novel searches? How about, tell me, can we do a cluster search? I want to identify all the children in my area with poorly controlled asthma who attended multiple hospital admissions but haven't seen community outreach teams. And I know that my area just spent several £100,000 on nurses to do exactly that job. And the answer was, yeah, sure. I said, oh, that could be interesting. I was thinking then about other ways it could be used. Imagine you're a regulator and you want to find out all about orthopedic departments and VTE, so venous thromboembolism, so pulmonary embolus after knee surgery. And you're going to go to a department in Sheffield and want to know in advance of going, are they similar to the national outcomes? Or perhaps you could run a search and compare the rates in the 6 weeks after the surgery and see if there was any difference from other places. Perhaps you could be a researcher who now had a newfound interest in stockings and said, okay, they've got evidence in the past, but now that patient stays are shorter and anticoagulants have changed, do those guys still get the same level of protection wearing stockings than not? So I was also wondering, how about if you're a provider and you wanted to see if you included just small plates as one of your impacts in your course, would that make a difference on the HbA1c or the weight of the patients going through? So, and apparently that could be possible too. I'm going to tell you a little story now about my work as a GP, and it's a story from yesterday, and it's brilliant and it's personal and unusual. So I got to see a 4-year-old boy whose mum was worried that he might have autistic spectrum disorder. And she cited some very minor things to do with sensory processing problems. Rowan hadn't talked till age 2, but his mum was good. She read to him and she talked to him a lot. Rowan did something strange. He was sat in the bath singing, and it just turned out that his first main words were singing the alphabet perfectly in reverse. His journey hadn't changed. He'd stayed on that track, and now he's age 4. His mum pointed out that he didn't like reading the normal school books. He was halfway through her Dan Brown novel. And I thought, this guy is going to change the world. I'm in no way like Rowan. I do hope he has a great future. But what I know is if I get the right collaborators around me with the right inspiration, that we can go ahead and make some unbelievably magnificent change. I'm going to try dip back into the slides, so bear with me, just to show you a little thought experiment about a different way of thinking. Okay, so hopefully that slides up, and I'm going to show you just an idea. Now, this is actually based on real data. This is perinatal mortality data, so a bit grim to think about. And this is 20 years of improvements across the English system, come from the Office of National Statistics. I'll be very clear, it's got nothing to do with our study. It's just a demonstration to understand speed of change and the effect of it. So what we can see to start with is that we've got an improvement over time of death rate, which is obviously a fantastic thing. But I'd ask the question, is our country as good as other countries? And for some of these metrics, the worry is they might be better, they might be here. And it makes me wonder, how did they get there? Well, first we need to understand how we got there. And this is iterative change, where individuals have done little experiments and had little trials in their areas, found something worked, shared that good practice, taught it to their students and to their trainees. Those trainees have adopted it. They've gone to practices that are doing it well, practices, but departments have done it well, moved between departments, and slowly those ideas have spread. In this example, there have been no new drugs, and babies are still born the traditional ways or with cesareans. I wonder, though, if we wanted to reach this point down here, and other people have done it, their trajectory must have been like this. They've got better faster. Perhaps they've got a route of quicker iterative change to learn from experiences. I want to show you a different graph. This one's totally made up, and it's the exact same graph in reverse. I think this could relate to the letters project I did in 2017. Every year, the number of letters to GPs was increasing. And what happened, if we'd left it, was exponential growth going on forever and ever. What actually happened is that a cross-collaboration idea came across to ask administrators to file these results, and a safe process was found. And what we started with was some early adopters who wanted to try it out, and I was one of them. That overall made very little change to the system, and so we got regulators on board and worked out governance and insurance and other things, and lo and behold, it became a national project. Teaching went wild around the country, and so I'm sure we saw a significant drop in the time spent filing letters. Once that happened, though, we've got a single intervention just once. It's taken a year or 2 to implement, and then we could expect from then on in, not that, because I can't hold it straight, but actually the number will probably rise because it was a single intervention. I'm going to zip back out of that and back to something else, so bear with me. So systems thinking does understand structural blocks for change, but it doesn't always necessarily respect them. If we want to shape the solution to be the best, then sometimes a new technology will shape the world as well as being shaped by it. I don't believe that what we're suggesting is the solution, but I do believe is the best vehicle I've ever seen that can get us to a better place. We can't have the same model of research and implementation we've always had as the rest of the world and technologies adapting quicker. I feel it's morally wrong to adapt slowly when the problems we're facing are killing us. The faster we understand what works and the quicker we stop doing what doesn't work, the better the results will be for our patients. In short, we need a different way of thinking that allows us to see the harms of slow adoption as well as help us coordinate and harness the powers of iterative testing and experimentation to create new opportunities. Governance structures will need to be developed to ensure that a new technology that could be used for good or bad is optimised for the people it's set to serve. Ethical considerations are needed as well as practical insights on how the technology can be developed. Broad-scale collaboration between specialties and specialisms will be needed to get every stakeholder represented who wants to be part of the solution, not part of the problem. The full benefit of the technology will not be met by normal procurement rules either. If we want coordinated population health in a mixed economy of providers, we can expect to lose the ability to make comparisons between areas if they're served by a different solution. Each of these smaller areas will also have smaller data sets, and therefore it will take them longer to scale to reach patterns of understanding what's working and what's not. And we're worried that that would slow the speed of human learning through iterative development. We found implications in our project for ICBs who could have better control of their budgets, real-time detail of who's getting what care, and can then spot the difference in uptake to life-saving courses between areas. Their views, quota setting and dashboards will not contain patient-level data. There are implications for PCNs who, without help, will generate huge additional amounts of work within overstretched GP practices who are struggling to deliver core services. Having identified and uploaded the patient cohort, the rest of the process is automated. It saves time for sending letters, receiving responses and making referrals. There are fewer concerns with data sharing if practices can be empowered and supported to do supplied and approved searches of their own data. Patients will also have more choice and flexibility over attending courses, safe in the knowledge that they're attending the programme that's got the highest chance of success for them. Perhaps the 4.8 million people who won't have access to an NDPP course this year could instead receive an online metabolic health booklet to help their food choices. Or perhaps we test that approach just on a small sample. Researchers may have more work to do too. Instead of waiting 5 years to see the effects of a course, using reverse searches into GP records could generate information regarding changes to metrics in the GP record to map against any intervention that's tried. That could highlight more effective measures in some patient cohorts than others. Lastly, commissioners of national services will benefit from this real-time research to better suggest changes in access to courses. They'll have comparable metrics between providers to better decide on who to use for future contracting. Our hope from today is that in this safe space and this broad coalition of health and IT professionals, we can work together to solve one of the biggest issues facing the NHS. Today, Scott showed you how this approach can improve NDPP referrals. Erin showed you how Medibase can apply an existing and tested technology to improve population health across the country. I've hopefully shared how wide-scale adoption of this technology could maybe save the NHS. I'd like to open questions to determine how the solution we've described could help the work you do wherever you are in the health or social care system. Thank you.
Thanks so much, Tom. Thanks also for all the questions that have come in during the session. We're just going through the questions and fielding them to the speakers. So I think from the look of the questions that have come in, the majority of them I think would be addressed to Scott. So what I'd like to do is just hand over to Scott and he'll cover off as many as we can in the next few minutes. We still do have 10 minutes left in the session, so hopefully we can get through a few of your questions before we wrap up.
Thanks, Jai. What I'm going to do, folks, if it's okay with you, is sort of answer a number of your questions all at once. One of the things that we're planning to do is gather in all the questions that have been answered, type down some responses and share it as a additional document after this event. So we'll give sort of a full Q&A document out, but there seems to be some themes coming through. So I'm going to start with the easiest of the questions, which is to you, Adele, and it was, yes, CPG did code back in the limits of the pilot, but that would obviously be different depending on how it was managed in other areas. In terms of the outcome data, once the patients are handed over to the local provider, that's not really something we can comment on in the context of this webinar, but I can say that there was a slight difference of 4%. 4% more people who are in program from the opt-in than from the opt-out. So actually, it's fairly negligible. It's not a significant enough difference for us to say one has any real benefits or merits over the other. The big question that everybody has seemed to be posing, and I should have put 3 or 4 exclamation marks next to it, is IG. We have a nice little outline of how we boxed off the IG, which I will happily share in the Q&A document. But just to say that we broke it down into the process steps. There was those 4 steps outlined on that slide. And essentially, Care Plus Group were under contract with the CCGs. They already had appropriate access and data sharing agreements in place. We then put one into place so that the data being moved between them and Medibase, that was covered off under a separate agreement. And likewise, when it was going from Medibase to the provider, that again had its own overarching, remembering that the national provider framework for NDPP means that these contracts are held between the local providers and NHS England. Therefore, they had all the appropriate paperwork and a robust process underneath it. But more than happy to outline that in the document, which will circulate to everybody who's attended the meeting. Thank you.
Okay, thanks, Scott. We do have one specific question, which I think might be one that Tom can take. That one is from, let's see, just checking who it's from. So, sorry, just double checking which one we're going for here, because we've got so many different questions coming in. Did the potential referral list have clinical oversight to ensure all people prior to being passed to Medibase were appropriate for invite?
Yeah, I think it's a great question, because we do want to target to exactly the right people. In this instance, yeah, I don't believe that there was a GP or anyone looking through the list. And I think the whole purpose of these questions is to work out where you can neaten and get better for future. It's difficult to imagine that people should be excluded if they met the criteria, though. And so I think the important thing here was the pure searches. There was actually quite a lot in the searches that had gone on that made sure we excluded other people. We just went a bit above and beyond. So we made sure, if you had diabetes and you're in the range, that doesn't count. If there are various things we've done to make it as neat as possible. But to answer your question, no. And I think it's an interesting thing to develop the conversation about, because if you're using it for other things, how pure can the searches be? Or do we need patient engagement to help them decide if they're suitable? But yeah, great question. Lots to think about.
Okay, thanks. We do have one question that I think Erin will be able to answer quite quickly and in a quite straightforward manner, which is it free to respond to text or standard text rate from mobile provider? If I can pass that over to you, Erin.
Yeah, great question. Short answer is yes, it's free for the patient to respond.
That was a very short answer. Okay, just looking at the other questions that are still coming in as we speak. Another one for you, Scott. Do the pilot practices have a plan regarding following up on those patients who declined NDPP?
Nothing that was built in as part of the pilot. However, the engagement lead will follow those practices up in 12 months' time when it seems optimum to refresh the searches and see if those patients are still in there. So yeah, that's a different aspect of managing these patients and the invitations for them. One question that was in there that I will just touch on briefly is, as we hope to move forward with this project, we as an ICB will be funding this. This isn't something that is being commissioned out with us. We would look to support this. So actually we're taking on the cost burden from the primary care colleagues who would traditionally have had to pay for paper, envelopes, stamps and practice staff time. We will be taking that on. That's something that we're looking to do out of our transformation funding that we have for this year. But that's obviously would have to be discussed between yourselves and your purse holders and etc. It's all very complicated and all very different. Somebody had just put a question here. Sorry, we're utilizing text technology and we're bouncing your Q&As around between us on WhatsApp. Quit running NDP. Is it ready for upskilling? Oh, that one is for you, Erin, from Adele, colleague of mine, Adele Morris.
Can you tell me the question, Scott? Sorry, I've lost where we're at.
Feels like a secret Santa, doesn't it?
It does. So
And
the
Erin, this
question is,
yours.
can ICBs make contact with Medibase to look to run the NDPP process? Is it ready for upscaling?
Yeah, definitely make contact with us. I don't know if Jai wants to take that and run with
Yes,
it,
absolutely.
or
Yeah, happy to take that. Yes, obviously we ran this pilot project. It was extremely successful. We're all really excited about the results. It's had a lot of interest, a lot of media coverage, because it has been, you know, such a phenomenal success. And we knew that we would see, you know, an uptake in patient referrals to the programme, but even we were all surprised at just how dramatic that increase was. So we'd love for you to get in touch. We can have a discussion with how this could work in, yes, at your ICB or in your specific care setting, and happy to take that forward. There'll be a contact slide at the end of the presentation where all of our contact details will be listed. So you're very welcome to get in touch at that point.
Can I jump into Salma's question? It'll be very quick. It's a brilliant question. She's asked us, yeah, Salma Mihas. So I think we might have had some contact before, and she's asked, has the programme been tailored for diverse communities, addressing any language or digital barriers? And again, it's just so helpful because I know she works in this area. I know she knows lots and lots about it. And I just would want to reach out and say, very, very happy to collaborate with you and maybe catch in with you to work out how it can be done better. The whole point of clustered searches is you can pull out these metrics. You can, you know, cross-test, A/B split test various approaches in people's native languages or otherwise. That's the whole beauty of the digital communication. And then hopefully prove that you can include people more and you can get better uptake and better completion rates and better results. So yeah, that's exactly where I think this technology takes us to. It just needs to be applied in a safe and ethical way that gets the best results. So thank you.
Yeah, I think as we've only got 1 minute left and we want to make sure we finish on time so everyone can get back to their day jobs, we'll just give you our contact details and a little bit of information here. There is a link on our website to download the full white paper report. You can go to medibase.com and navigate from the homepage, or you can go directly to this link. You've also got contact information for myself and Erin at Medibase, and our colleagues, Dr. Milligan and Scott Walker. So please feel free to reach out to us at any time. And so all that's left to say is thank you so much for taking the time to join us today. We really appreciate you allowing us to share all of the learnings from our project. We really hope it's been an interesting and useful session for you. And we really look forward to hearing from you soon. So thank you very much.